2, and you'll see that there is a checklist available which covers all of the criteria required for Stage 2 reporting. And then under Meaningful Use Guides, you'll see resources for our 2014 clinical quality measures. There is both the Clinical Quality Measure Guide, which is an overview of each clinical quality measure and where the information is documented in ClinicSMD, so you get an idea of what's being tracked and how. And we've also provided these clinical quality measure specification sheets that were made available by CMS. This gives you detailed information about how the measures were developed using what criteria, the clinical rationale and clinical recommendation statements, and even the improvement notations. I would like to once again point out a feature that we've built into the Clinical Quality Measure Dashboard report, and it's the ability to search the value sets provided in these specification sheets. I'll pull one on screen here for you to see. These specification sheets have the measure title, the clinical quality measure, and then the disclaimers, copyright information, clinical rationale, clinical recommendation statement, who developed the rule, what information they based the rule or the measure on, excuse me, and the improvement notation statement. This gives you an idea of what your percentage means when the report is generated in ClinicSMD. For some measures, a higher percentage indicates better quality, while others, a lower score or lower percentage indicates better quality. So it's important to pay attention to that so you can understand what the measure is and how to apply it to your practice. Scrolling down, it gives detailed information of how the initial patient population and denominator is tracked, any denominator exclusions available, which automatically pulls the patient out of the denominator based on certain criteria that's available, and then how the numerator is tracked. Continuing down, there's a section called Data Criteria, QDM Data Elements. This is where that search value set tool in ClinicSMD becomes very handy. You'll notice in a lot of the specifications that people in the denominator and or numerator are broken out by a specific diagnosis, are on a specific medication, have a specific lab value result. And this gives you detailed information about what medication specifically they're looking for, the specific diagnosis or SNOMED codes, or specific LOINC codes that are attached to, say, lab result values or radiology studies or other procedures. So it allows you more granular information to see how and what they're looking for in terms of the reporting in ClinicSMD, so you get a better idea of why patients perhaps didn't fall into the numerator when you think they should have. To use this tool, you would select one of these data elements, such as this, diagnosis of heart failure, using the following value set. It's a string of numbers. You can copy that number, and in ClinicSMD, click the Search Value Sets button, paste in the value set ID, and then put in the CMS measure number, which again is available right here in the second row of all the specification sheets. It's report number 135, and click Search. So for this report, a diagnosis of heart failure is tracked in ClinicSMD by either ICD-9 codes or SNOMED codes. Okay. Moving on, we'll go ahead and jump straight into the reporting. Today we will be covering 6 of the non-core clinical quality measures. All of them fall under the clinical process and effectiveness domain. And they are CMS 127, Pqrs number 111, pneumonia vaccination status for older adults, CMS 128, Pqrs number 9, antidepressant medication management, CMS 130, Pqrs number 113, colorectal cancer screening. CMS 134, Pqrs 119, screening, diabetes screening, urine protein screening. CMS 135, which is also Pqrs number 5, heart failure, ACE inhibitor or ARB therapy for left ventricular systolic dysfunction. And CMS 143, which is also Pqrs 12, primary open-angle glaucoma optic nerve evaluation. The first measure, CMS 127, pneumonia vaccination status for older adults. This is a carryover from the original clinical quality measures that were first introduced in 2011 with the stage 1 reporting requirements. It's the percentage of patients that are 65 years and older who have ever received a pneumococcal vaccine. This would be documented in ClinicalMD in the immunization tab. Okay. Simply add the specific vaccination and click OK. If the patient did not receive the vaccine in your office, mark the pre-existing vaccine checkbox. And that sets it as a historical vaccine. Okay. This measure is specifically tracked by the CVX codes, those immunization codes that have been provided by the CDC that you set up in your clinic setup for your immunization orders. To briefly touch on that, you would go into your orders list, select your immunizations, select the appropriate vaccine, and then set the immunization code, which is also otherwise known as the CVX code. It's a quick drop-down list. This information is available and has been given by the CDC, and I provided it to all participants in the original Meaningful Use Setup Guide webinar that we had. It was our first session. I will be sending out this spreadsheet in addition to some other useful materials to all of our clients so that they have access to them when they're ready to go ahead and set up their clinic. Okay? Moving back on to reports. The next measure is CMS 128, which is also Pqrs number 9, antidepressant medication management. And there's two populations, two rates that are being tracked. Patients that have received antidepressant medication for at least 12 weeks of continuous treatment during the 114-day period following the index prescription start date, which is defined as the initial start date of the medication. And also patients who have received antidepressant medications for at least 180 days or 6 months of continuous treatment during the 231-day period following that initial prescription start date. The diagnosis for your patients that have been diagnosed with an active disorder of major depression is indicated in either the Diagnosis tab in an encounter or in the RxDX list in the problem list. The medications are then tracked either, well, mainly through entering the initial prescription, so your initial onset date of when it was first issued, in the prescription tab. So the issue date that's there is known as the index prescription start date. Medications include Atipin, amitriptyline, Zoloft, Wellbutrin, etc. The full list of those medications that are included in that medication set, again, are available in the specification sheet, and it's quite lengthy. So I really encourage you using these value set lookup tools. In this measure, a higher score indicates better quality. So the higher the percentage, the better quality of care is being given for those patient populations. Next measure is CMS 130, which is also Pqrs number 113, colorectal cancer screening. Specifically tracking the percentage of patients 50 to 75 years of age who have had appropriate screening for colorectal cancer. Tests that detect cancer are colonoscopies every 10 years, flexible sigmoidoscopy every 5 years, and fecal occult blood tests. The fecal occult blood test is specifically tracked to the LOINC code, which is the laboratory observation codes that are attached to the fecal occult blood test result in your orders list. Okay. So again, going back to your orders list in clinic setup, you would have your orders up here and the associated results for your order here. This is where you would enter the appropriate LOINC codes. If your labs are sending this information in the lab result files we received from them via the HL7 interface, we will populate that information in ClinicSMD. But it's dependent upon the lab sending it, and not all send that information. The LOINC codes that are used to track this measure, again, are available in those value sets. Sigmoidoscopy would be entered as a procedure in ClinicSMD and is tracked either by the corresponding CPT or HCPCS for the sigmoidoscopy or a SNOMED CT code. Colonoscopy, much the same way, either by a CPT code or HCPCS code or a SNOMED CT code. In those instances, which you could do on a patient basis, depending on if you're doing sigmoidoscopies or colonoscopies for your patients. You could, for instance, use the diagnosis B76.51 and map the appropriate SNOMED code to that on your patient-by-patient basis, depending on the order. If all that you do for your office is colonoscopies, you could go ahead and set that up in your default list of SNOMED mappings in ClinicSMD. Either via the ICD SNOMED tab. Click Add. You would search for that diagnosis and then go ahead and map it to your SNOMED code. Or if that code is in your preferred list of clinic codes in the ICD tab, you could map it there as well. So if the code is here, you go to the far right and map it with the magnifying glass. In this case, a higher percentage indicates better quality of care. Next measure is diabetes urine protein screening, CMS 134, Pqrs 119. This is the percentage of patients aged 18 to 75 years of age with an active diabetes diagnosis who had neuropathy screening test or evidence of nephropathy during the measurement period. This information is coming directly from recommendations provided by the NCQA. And the clinical recommendation statement behind this measure is by the American Diabetes Association, is to perform an annual test to assess urine albumin excretion in both type 1 and type 2 diabetic patients that have had it with a duration greater than 5 years. For this report, that specific lab result for your urine protein screening is tracked by the LOINC code attached to the lab result in your clinic setup, your clinic orders. Next measure is CMS 135, Pqrs number 5. It's heart failure, ACE inhibitor, or ARB therapy for left ventricular systolic dysfunction. And it's your percentage of patients 18 years and older with an active diagnosis of heart failure with current or prior left ventricular ejection fraction greater than 40%, who are prescribed an ACE inhibitor or ARB therapy either within a 12-month period when seen in the outpatient setting or at a hospital discharge. The improvement notation, for this measure is that a higher score indicates better quality of care. The clinical rationale behind this measure is that in the absence of any contraindications, of course, ACE inhibitors and ARBs are recommended for all patients with symptoms of heart failure and reduced left ventricular systolic function. Both have been shown to decrease the risk of death and hospitalization. The diagnosis of heart failure is tracked by this measure either by an ICD code or SNOMED CT code, which is recorded in the Diagnosis tab in an encounter or within the Problem list in the RxDX list tab. The meds are then defined by their categories. And again, the full list, if you're interested, is available if you use those specification sheets and look up the corresponding value set. So any ACE inhibitor or ARB therapy would be included in this measure in terms of the numerator. ACE inhibitors include captopril, lisinopril, perinapryl, quinapril, raminapryl. And ARBs include candesartan, losartan, and valsartan. There are no exclusions built into this measure, meaning qualification-specific diagnoses for patients that automatically pull them out of the denominator in the report. There are denominator exceptions available, which are on a case-by-case basis, so it's not a blanket exclusion for a certain population subset. It's on a patient-by-patient basis, and it's based on the documentation of medical reasons for not prescribing an ACE inhibitor or ARB therapy. And you would do that in your report exclusions tab in the encounter, much like you would have done for your stage 1 clinical quality measure reporting. Next measure is CMS 143, Pqrs number 12, primary open-angle glaucoma optic nerve evaluation. It's your percentage of patients age 18 years and older with a diagnosis of primary open-angle glaucoma who have had optic nerve head evaluation during 1 or more office visits within 12 months. The diagnosis for primary open-angle glaucoma is tracked in this measure by either an ICD code or SNOMED code, which are both recorded in either the Diagnosis tab in the encounter or within the Problem list in the RxDX list tab. The two procedures that are specifically being tracked for the numerator portion of this measure is the cup-to-disc ratio, which is tracked by a LOINC code rather than a procedure code, or an optic disc exam for structural abnormalities. Again, it's being tracked by this measure by a list of LOINC codes, again, not specific to a procedure code. So you can either set this up as an order in your clinic list in ClinicSMD and attach the correct LOINC to it, or you could also set this up as a vital signs order depending on how you want to document the information, such as the cup-to-disc ratio, and attach the LOINC to your vital signs order in ClinicSMD. Again, neither one of those procedures are tracked for this measure by a procedure or HCPCS code. For anybody that hasn't participated in the previous clinical quality measure webinars, I'm going to circle back a bit and mention the relevance of this Pqrs number. For 2014, the electronic file format that can be generated out of a 2014 certified system can be used for both your clinical quality measures reporting and your Pqrs reporting for the year by the Qualitynet portal, Physician Quality Reporting System portal, that it's known as Qualitynet. And it's a simple file upload process once you log in, a batch upload for your files. If you choose to use this method where you report them together for 2014, your report period for your clinical quality measures will be for the entire year, not just your 90-day report period for your meaningful use incentive for 2014. So for this report run, it would be for the entire year, not just for a 90-day period, since Pqrs is for the entire year. The same holds true for both reporting programs. You must select 9 clinical quality measures covering 3 of the health domains, such as clinical process and effectiveness reports. At the time of attestation for your meaningful use incentive, you would indicate that you are going to report your clinical quality measures along with Pqrs. You will then be able to continue your attestation by reporting your core and menu set measures for stage 2. They will then hold your payment, your incentive payment, until after they receive the Pqrs file no later than February 28th of 2015. If you're going to be using this method, they highly recommend that you submit test files prior to. Again, it's through the Qualitynet portal. It's sponsored by CMS, and you would log in with your IACS account. And you can submit test files, which are just generated out of ClinicSMD when you click Generate QRDA. Another thing to remember with your clinical quality measure reports, that there is not a target percentage provided, because for clinical quality measures, there's not a minimum threshold that you must meet in order to meet the measure, like there is with the stage 2 core and menu set measures. In terms of a status of green, which means target met, you can't have a denominator of 0. You can't report denominator of 0 clinical quality measures. You have to report some type of performance measure, even if it's 0 over 1. So your numerator is 0, your denominator 1. Okay. The recurring reports and provider defaults that are available for your stage 2 dashboard reports are also available for your clinical quality measure reports. Just briefly, for anybody that has missed the prior sessions we've held, to set up your provider defaults, which would be the 9 measures that you want to track, select the provider defaults radio button and mark the reports you want to track. And then either save by F5 or clicking the refresh icon. You can then set a recurring report schedule for your providers. And you have shortcuts available for the time period for your report. Quick options are last 30 days, last 90 days, year to date, or specified date range. And the frequency for the reports, you may either choose to run it daily, or specific days of the week. If you do it once, it would be considered a weekly report. You may also choose to run it monthly on either the first day of the month, the last day of the month, or a specified day of the month. By setting up a recurring report schedule, you save yourself a few steps of having to come in here and manually create a new report, select your defaults, and then run it and wait for the results. This will then automatically run for you on your specified day for the time period selected for the provider. And then for the requester of the report, which is the user that's logged in setting up this report, you'll get a system message notification in your messages list that you have a CQM report or a Stage 2 auto measures report to go look at. Once you click on the message, it will take you straight to your dashboard report where you could quickly view the status for your provider. Green for this status indicates the target was met on all selected measures. Yellow indicates that it's still in process, and red indicates that the target wasn't met on one or more reports. In this case, again, the target is you can't have a denominator of 0. And this is strictly for the clinical quality measures. For each measure, you'll then have a unique status of green or red. There's availability to view the specific patient details for each measure by clicking the magnifying glass to the right of your results. You'll then receive the list of non-qualified patients. Those are the patients that are in the denominator but not the numerator. For some reason, they did not qualify. You then have access to the numerator and denominator, exclusions and exceptions information. You can print out this list onto a hard copy, or you can click the Save As button and export it into an Excel spreadsheet if so desired. Okay, so we're closing that window. We return back to our main dashboard report. Again, I've built plenty of time in this webinar to ask as many questions as you may have. So I'm going to give you the opportunity to do so at this time. In the GoToWebinar tool on your right side of your screen, if it's minimized, just click the orange button to expand it. You'll notice that there's a section for questions. Click the plus mark to expand, and then you can enter any questions that you may have. I'll go ahead and give you about 5 minutes to do so. Ask me any questions you may have, and I'll answer them one at a time. Okay, looks like we've got a bunch of questions that have come in that we'll start answering. First question is, which domain did I say these Cqms are related to? At the top of your reports and below you will find them is the domain name. In this case, these all fall under the clinical process and effectiveness reports. This information is also available if you look at the provider default screen. They're broken out by adult recommended core reports, and then the subheadings are the domain names: care coordination, clinical process and effectiveness, efficient use of healthcare resources, patient safety reports, population and public health reports. For the non-core reports, they're just all listed under the non-core reports header, and then broken out by healthcare domain. When the report is run, the specific domain will be displayed, and the reports under that domain will then follow. Next question, how does one get an IACS account that you said one needs to in order to submit Pqrs reports to Qualitynet portal? This is a user ID that you obtain from CMS directly, and stands for Individuals Authorized Access to CMS Computer Services. Most providers should already have one of these set up because it's used for Pqrs reporting, other payment transactions through Medicaid, such as bundled payments, EFT, CMS administration, physician values, comprehensive primary care initiatives. Lots of CMS-driven systems are all available through this IACS user ID. It's not available to anybody but physicians' practices and their staff that will be reporting or logging in on behalf of them. Do I know if there is a charge to access Qualitynet portal? I am not aware of any charge. It shouldn't be. This is a portal that is provided by CMS strictly for Pqrs reporting. You can simply Google this information or log into the Pqrs site on cms.gov to find this information on how to register for specific CMS application for an IACS account. In this case, you would select the Physician Quality Reporting System. It was previously used for the ERX reporting as well. Next question, what do we click on if pneumonia vaccine wasn't done in the facility? In the encounter, when you're documenting the immunization, mark the pre-existing checkbox that indicates that the vaccine was performed elsewhere. You did not give that vaccine. Naturally, you wouldn't be completing it. The manufacturer is then automatically set to unknown, and it's documented as a historical vaccine. By default, the source is unspecified, but you can get more specific based on the information received from a school record, from a public agency, from a parent's written record, etc. In the notes field, you can document any other additional information. And you can still document any reactions that the patient may have had from that vaccine if they give it to you. Next question. I mentioned something about documenting an exclusion in a Clinics MD for both MU Stage 1 and Stage 2 reports. Where and how does one document these exclusions manually? Let me stress that these aren't really exclusions, and there is a definition difference between an exclusion and an exception. An exclusion is something that's automatically calculated by our system based on specific subpopulation information in the specification sheets to pull those people at the denominator automatically, such as patients with a specific diagnosis, such as your patients that are pregnant, they wouldn't be included in the denominator for a hypertension diagnosis. An exception, which is what I'm referring to on these case-by-case basis, are on a patient-by-patient basis if they qualify for not being included in the denominator. So it's not a bulk subpopulation, it's a patient-by-patient basis, such as a medication not performed for a specific reason, etc. This information is documented in the report. Oops, let's just complete that. Report Exclusions tab. This has been available since the initial Stage 1 rollout in 2011. Click the Add button, and you can either view the exclusions that were available for your Stage 1 reporting or Stage 2. And these are the categories. And again, all this information, when there is an exception available in the spec sheets that we provided, they're broken out into these categories. Communication from patient to provider, medical contraindication, medical or other reasons, medical reasons, patient intolerance, patient reason, patient refusal, and system reason. Click the plus mark to expand and view the specific exclusions available for that category. Okay. Next question. How does a primary care physician who does not perform the sigmoidoscopy or colonoscopy document it to meet CMS 130 CQM? Again, in terms of that report, which is looking for the specific procedures, sigmoidoscopy or colonoscopy, the value sets they provided are CPT codes and HCPCS or SNOMED CT code. In ClinicsMD, you can map SNOMED CT codes to a diagnosis code. And you can either do so at a bulk level for your entire clinic as a default in your ICD codes or your ICD SNOMED mapping in clinic setup. And you can do it on a patient-by-patient basis using, say, for instance, 76.51. You could then map it to the appropriate SNOMED code. Again, if you are a practice and you're primarily are sending your patients out for colonoscopies every 10 years, you can go ahead and do a clinic-level default mapping for your specific SNOMED code that's included in the value set for that report. Or if you don't want to set it through your clinic default, which you can do so from the Diagnosis tab by just marking the Clinic Defaults button, you can just do it for specific patients, depending on if you're doing sigmoidoscopies or colonoscopies. This is also tracked by the Fecal Occult blood test, which is a lab result that would be mapped to one of those laboratory observation codes, otherwise known as the LOINC codes. Next question. Generally speaking, is it sufficient to document an order which has a LOINC code assigned to it, or do we need an entry for the result panel associated with that order? For any of the measures that are looking for a specific lab result, you have to have one of the lab results in it. So if it's looking, say, for an A1C score greater than 9, you would obviously have to have the result value documented in order for that report to work, since it's tracking a specific population of the lab result values. In other reports, it just is looking to see if the order was performed. In that case, a specific result isn't being looked for. It's looking to see if the lab was completed. For the measures dealing with radiology orders, such as mammograms being completed, it's looking for a resulted mammogram. In the specifications, it clearly says mammogram result. In that instance, it's not looking for a specific result, i.e., positive, negative, lump found. It's just looking to see if the order was resulted. Next question. Do the spec sheets state on them what domain the clinical quality measure belongs to? No, they do not. The spec sheets do not show the specific healthcare domain, as that's kind of a subset that was developed by CMS and put them in this. That information is available in a couple of different places. It's available here in Clinics MD. The reports are all broken out by domain. Okay, care coordination, clinical process and effectiveness, efficient use of healthcare resources. It's also available on the Meaningful Use Stage 2 checklist we provided. The reports are broken out by domain. There's also some additional links that have been provided in that checklist so you can read further information on the domains that are being used. The resource we provided is the U.S. Health Information Knowledge Base Guide. That information with those useful links are also included in the Clinical Quality Measures Guide that can be downloaded here. Next question. Does an order need to be completed in order to count in the CQMs? Yes, specifically if the CQM says resulted, which they all do. Some of them are looking for a specific completed resulted amount, a specific value, such as positive, negative, A1C greater than 9, etc. Some do not specify a specific result, but it indicates that they want a completed resulted order. Are these specifications for the CQMs accessible from the dashboard? Again, they are under the Help menu in Clinic MD, under Meaningful Use Stage 2, the 2014 Clinical Quality Measures. Both the CQM Guide and the Spec Sheets that correlate to the reports available in Clinics MD are available for download. Is there a way to print the specific vaccine information sheets from Clinics MD? No, we do not store the actual vaccine information sheets. We store the specific codes associated with that vaccine information sheet that is required for your immunization reporting. It's done by a specific barcode that the CDC is looking for, which is then mapped to the CVX code, which is attached to the order and clinic setup. That's why it's very important to have the correct CVX code attached to your vaccine orders, because then the appropriate vaccine information sheets, information that needs to be reported to the vaccine information registries are attached to the file that's sent to them. Next question. When mapping a diagnosis code to a SNOMED code, sometimes multiple SNOMED codes pop up with the same description but different code. How do you know which code to select? Both are appropriate. Some are more appropriate than others, and it depends on, for clinical quality measures, what SNOMED code is in that value set. But the same code, the reason why they're displayed twice is that we have both the British extension and the U.S. extension available in Clinics MD because both are used in the value sets for the clinical quality measures. And sometimes they have the identical descriptions. So if you're using the SNOMED code, especially for your clinical quality measure reporting, again, really use those value sets that are available for viewing using this button here for each measure. You can also just do a blank search for the measure, even if you haven't looked up a specific value set ID, if that's a little too complicated. You can type in the measure number and just click search. And all the information being tracked in the measure by code or value set is included. So for this case, all the diagnoses tracked by either ICD-9, ICD-10, or SNOMED CT are displayed. Okay. Any other questions for me today? One last question just popped in. Do I know how to obtain vaccine information sheets? Yes, the CDC provides those vaccine information sheets. If you just do even a quick Google search, you can go to the CDC's vaccine information sheet website, which has them all available for download, or you can go straight to the CDC website. They have a search box. You can type in vaccine information sheets or VIS, and it will pull a list. There's not a lot of them out there. The exception is for our clients that are in Michigan, which have to use their own specific vaccine information sheets provided by their immunization registry system known as MICR. They have to get the vaccine information sheets directly from them on their website. Any other questions for me? Okay, looks like we do not have any more questions today. Those were some great ones, so thank you so much. Again, I will be sending out some emails in the coming weeks, well, not even coming weeks, coming days, excuse me, with some more detailed information and some very useful resources that are available to you to help you along your meaningful use path. I'll send you links on specifics such as definitions of SNOMED, what they are, how to use them, what they mean. I can provide links on that. I'll provide you links on the security risk analysis tool that healthit.gov released in coordination with the ONC to help you meet the security risk analysis measure, and some other resources that have been made available in recent months by CMS and the ONC, and even healthit.gov. So keep a lookout for those emails from me. They are generally sent from news@clinicsmd.com. So also be sure to add that to your address book to make sure that those aren't being blocked by spam or junk, or being directed to junk mail folders. If you have any questions after today's webinar, feel free to shoot me an email. I can be reached at mary.brunson@clinicsmd.com, or you can shoot an email to our support line at mdclientsupport@clinicsmd.com, and we'll be sure to get back to you as quickly as possible. Thank you so much for participating today, and I look forward to hearing from you folks again. Our next session is next Tuesday. We'll be covering the next 6 reports under the non-core measures, and it'll be from 2 to 4 Central, just like today's session. Thank you very much for participating, and I hope you have a wonderful afternoon.